A preoperative evaluation is done before an individual can undergo surgery to assess their health. This is important because surgery and anesthesia are stressful events that can exacerbate underlying diseases. The goal of a preoperative evaluation is to identify diseases and risk factors that increase the risk of surgery and anesthesia, and to come up with strategies to reduce that risk. The American Society of Anesthesiologists created the ASA Physical Status Classification System for preoperative evaluations. This classifies individuals into 6 groups. 1 is a healthy person. 2 is someone with mild systemic disease. 3 is someone with severe systemic disease. 4 is someone with severe systemic disease that is a constant threat to life. 5 is a moribund person who is not expected to survive for long without the operation. And finally, 6 is a declared brain-dead person whose organs are being removed as a donor. If the surgery is an emergency, the physical status classification is followed by E for emergency. In addition to the ASA physical status, other operative risk factors include age, comorbid conditions in addition to systemic diseases, the operative procedure, the type of anesthesia, and finally, the surgical team and resources. That includes the surgical and anesthesia team, duration of surgery, and anesthesia, equipment, medications, blood, and post-operative care. The first key risk factor is age, and much of the risk associated with age is due to comorbidities like cognitive and functional impairment, malnutrition, and frailty. Next is exercise capacity, because those with good exercise tolerance generally have low risk. Next is complete medication history, specifically including over-the-counter, complementary, and alternative medications, which could cause an increased risk of bleeding. Most medications should be continued up to and including the morning of the operation, but some should be discontinued preoperatively. For example, monoamine oxidase inhibitors, or MAOIs, may need to be stopped 2 weeks before surgery because of the risk of drug-drug interactions with anesthesia medications. Selective serotonin reuptake inhibitors, or SSRIs, should be discontinued 3 weeks before undergoing high-risk procedures like central nervous system procedures. In some high-risk cases for venous thromboembolism, the oral contraceptive pill may need to be discontinued 4 weeks before elective surgery because of the increased risk of venous thrombosis. Aspirin should be discontinued 7 days before surgery, unless there's a high cardiovascular risk. Thienopyridines, like clopidogrel, should be stopped at least 5 days before surgery, and warfarin should be stopped 5 days prior to invasive procedures, all because of the increased risk of bleeding. Selective cyclooxygenase 2, or COX-2 inhibitors, and other non-aspirin NSAIDs are okay to continue until surgery, as long as there's no significant bleeding risk with the procedure. On the other hand, if there is a significant bleeding risk, then the timing of discontinuation depends on the specific NSAID. In addition, individuals should be asked about alcohol, smoking, and illicit drug use. Alcohol and smoking increase the risk of surgical site infections and cardiopulmonary complications. Individuals with chronic opioid use may have tolerance and require higher than usual opioid doses in the intraoperative and postoperative period. Those who abuse barbiturates or amphetamines are at risk for drug withdrawal in the postoperative period, since they won't be getting access to any of these drugs. It's also important to identify a person or a family history of anesthesia complications, like malignant hyperthermia, which is a rare complication of anesthesia that can be due to an inherited condition that's autosomal dominant. At the time of the initial preoperative evaluation, a brief self-administered questionnaire is completed to determine functional exercise capacity, including the ability to climb up a flight of stairs, walk up a hill, walk at ground level at 4 miles per hour, or perform heavy work around the house. Individuals that are able to perform these tasks have a good exercise capacity and need no further testing or preoperative cardiac evaluation, regardless of the risk of the planned procedure. On the other hand, having a poor preoperative exercise capacity is considered an important risk factor for cardiovascular and other complications. It's also specifically important to ask about cardiac symptoms and conditions such as individuals with myocardial infarction in the previous 60 days, or with unstable angina, decompensated heart failure, significant arrhythmias, or valvular heart disease that affects their hemodynamics. These individuals are at a very high risk for perioperative myocardial infarction, ventricular fibrillation or primary cardiac arrest, complete heart block or heart failure, or even death. To better estimate cardiac risk, it's important to check for symptoms of coronary heart disease, such as angina, dyspnea, syncope, or palpitations, as well as any history of ischemic, valvular, or cardiomyopathic heart disease or congestive heart failure. Comorbid risk factors for cardiac disease should also be identified, such as hypertension, diabetes mellitus, chronic kidney disease, and cerebrovascular or peripheral artery disease. Finally, it's important to determine if the surgery is considered high risk for major adverse cardiac events, such as intrathoracic, intraperitoneal, or suprainguinal vascular procedures. These elements make up the Revised Cardiac Risk Index. The physical examination should focus on the cardiovascular system, including the blood pressure, auscultation of the heart and lungs, abdominal palpation, and examination of the extremities for edema and vascular integrity. For those with known heart disease that are undergoing an immediate or high-risk surgery, a resting 12-lead ECG should be done. ECG may also be done for asymptomatic individuals undergoing high-risk surgery, as well as for individuals with at least one risk factor for coronary heart disease, such as obesity, diabetes, smoking, hypertension, or hyperlipidemia, or with poor exercise tolerance. The ECG tracing should be evaluated for the presence of pathologic Q waves, or significant ST segment elevation or depression, which raises the possibility of myocardial ischemia or infarction. The ECG might also show left ventricular hypertrophy, QTc prolongation, bundle branch block, or an arrhythmia. It's also important to ask specifically about pulmonary symptoms and conditions. That includes exercise intolerance, cough, and dyspnea, as well as risk factors like age over 65, being a smoker, and having COPD, asthma, obstructive sleep apnea, interstitial lung disease, pulmonary hypertension, or low serum albumin. Individuals with these conditions, or who have intraoperative risks associated with pulmonary complications, should have their risk factors managed aggressively prior to elective surgery. This involves careful history and physical exam regarding symptom severity and select diagnostic testing. If not already done in the last 6 months, it's reasonable to obtain a chest X-ray in individuals over 70 years, those undergoing high-risk surgery, including upper abdominal, aortic, esophageal, and thoracic surgery, those with cardiac pulmonary disease, or with an unreliable history and physical exam, and it may be considered in individuals that are severely obese. The chest X-ray may show signs of heart failure, cardiac chamber enlargement, or abnormal pulmonary vascularity, suggestive of pulmonary hypertension, warranting more of a workup. Smokers should stop smoking at least 6 to 8 weeks before the operation. Preoperative pulmonary function testing with spirometry should be obtained in patients with unexplained dyspnea or reduced exercise tolerance. Individuals being considered for lung resection or reduction or high-risk abdominal procedures, and for those with restrictive lung disease. A forced expiratory volume in 1 second, or FEV1, below 70% predicted, and a forced vital capacity, or FVC, below 70% of the predicted value, and an FEV1-FVC ratio below 65% of predicted value is a risk factor for pulmonary complications after surgery. Finally, individuals must be screened for symptoms of obstructive sleep apnea with questionnaires, since it's often undiagnosed, and increases the risk for post-operative medical complications like hypoxemia and respiratory failure. Strategies may be implemented to reduce risk of pulmonary complications, including inspiratory muscle training, avoidance of pancuronium as a neuromuscular blocking agent, and the post-operative use of incentive spirometry or other lung expansion methods, such as the lung exercises and chest physiotherapy, and continuous positive airway pressure ventilation, or CPAP, although the evidence for some of these interventions is still limited. Preoperative laboratory testing is done when there's a specific clinical indication. First off, pregnancy should be ruled out in all reproductive age women prior to surgery, either by asking about the possibility of pregnancy or with a pregnancy test if necessary. Next, a CPC is often done to check the hematocrit in all individuals who are undergoing major or complex surgery, and individuals undergoing immediate surgery with ASA grade 3 to 4 who have cardiovascular or renal disease with recent symptoms. It's also done in younger individuals undergoing surgery that could cause significant blood loss, as well as those with anemia. Next, a low platelet count isn't a concern for most surgeries, but it may increase the risk of bleeding in certain cases, especially when the level is less than 50,000 per microliter. A platelet count is done for neuraxial anesthesia, so a spinal or epidural is planned. If a bleeding disorder is suspected, anticoagulant medication is being taken, or there is an underlying chronic liver disease, then a platelet count, along with a PT, PTT, and INR are usually checked. To test renal function, serum creatinine should be checked in all individuals with an ASA score 3 to 4 who are undergoing intermediate or high-risk surgery, and those with an ASA of 2 if they are at risk of acute kidney injury, or AKI. For major or complex surgeries, renal function should be tested for all patients with ASA 2 to 4, and those with an ASA of 1 at risk of AKI if hypotension is likely, or when nephrotoxic medications will be used. A serum creatinine higher than 2.0 milligrams per deciliter, or 177 micromole per liter, is predictive of having postoperative cardiac complications. Alright, as a quick recap, the ASA physical status classifies individuals into 6 groups. 1 is a healthy person, 2 is someone with mild systemic disease, 3 is someone with severe systemic disease, 4 is someone with severe systemic disease that is a constant threat to life, 5 is a moribund person who is not expected to survive without the operation, and finally 6 is a brain-dead organ donor. The history should be done to assess age-related limitations, exercise capacity, medications, and any personal or family history of anesthesia complications. Individuals with recent myocardial infarction, so within the previous 60 days, or unstable angina, decompensated heart failure, high-grade arrhythmias, or hemodynamically important valvular heart disease are at a very high risk for perioperative cardiac complications. Individuals should be assessed for cardiac risk using validated tools such as the RCRI, and then stratified to additional testing such as 12-lead ECG, left ventricular function testing, or stress testing. Smoking should be stopped 6 to 8 weeks before surgery. Individuals with restrictive lung disease, or those undergoing thoracic resection surgeries, should get pulmonary function testing with spirometry, and everyone should be screened for obstructive sleep apnea with questionnaires. Strategies to reduce pulmonary complications can be implemented depending on the condition identified. Finally, selective laboratory testing should be done for individuals with underlying risk factors.